Hello everyone and welcome to QuickMed, where medicine is explained quickly and easily. Today we will be discussing knee osteoarthritis. We'll first go over some knee anatomy, discuss the underlying pathology in osteoarthritis, as well as what to look for on imaging, so let's get to it. Alright, let's start by looking at the knee joint. When it comes to the knee joint, we need to know about key structures that are involved here. So the first are your four bones, your femur, your tibia, fibula, as well as your kneecap, known as the patella. Next are your four ligaments, your anterior cruciate ligament, your posterior cruciate ligament, as well as your medial and your lateral collateral ligaments. And then along with our four ligaments, we also have two types of cartilage that we need to be aware of, our lateral and medial meniscus. And then finally, we have our two tendons that we need to be aware of, the quadriceps tendon as well as the patellar tendon. It is these structures, the quadriceps muscle, the quadriceps tendon, the patella, and the patellar tendon that allow us to forcibly straighten or extend our knees. When it contracts, the quadriceps muscle pulls the patella proximally. And as it is pulled proximally, the patella pulls the anterior tibia proximally, which rotates the knee into extension. Anatomy can be pretty confusing, but it can also be very fun and easy to understand when you can piece it together in this way. So we've now covered the bones, the ligaments, the cartilage, as well as the muscles and tendons that are involved in the knee joint. But any overview of the knee joint would not be complete if we did not discuss perhaps the most important and most interesting structure, the articular cartilage tissue. So what is so special about this articular cartilage? It's actually specialized material that coats the ends of bones that bear against one another in our joints. And then within the joints, this articular cartilage is lubricated with this thick, viscous synovial fluid. And our articular cartilage is actually very impressive. It has some properties that you should be aware of. First, it's a very slick and slippery substance, and we haven't been able to invent anything to take its place just yet. And as you can imagine, this property is what allows us to move our joints easily and smoothly. Another feature is that our articular cartilage has no sensory innervation, so it has no nerves in it to feel any touch, pressure, impact, or friction. And this is actually a good thing because our joint-bearing surfaces are under significant loads and stresses each and every day. And although our articular cartilage has some of these great features, one downside is that our articular cartilage has no capacity to heal or regenerate. And this is what leads us to this very common problem known as osteoarthritis, which is where you have joint inflammation associated with articular cartilage degradation. And so how does this articular cartilage degradation take place? It's really just with daily use and the passage of time, which is why osteoarthritis is more common in older patients. There are also other conditions that can expedite this process of degradation, whether it's an intra-articular infection or repetitive trauma from work or sports. But regardless of how you get there, the end result is the same. With this loss of articular cartilage, you expose this layer of bone that sits right underneath. And unlike cartilage tissue, bone is not slick and slippery, and it's also loaded with sensory nerves. And so when a person gets to the end stage on arthritis, also known as bone-on-bone arthritis, which is where the two surfaces of bone are grinding against one another, it can be very painful for patients. So when we're considering a case of osteoarthritis, we really need to look at the history here. Is the patient older, or are they a younger patient who's participated in impact sports or physical work activities that have exposed their joints to abnormal forces over a period of time? Patients will often present with pain, swelling, stiffness, and these locking or catching sensations with movement. But these complaints, as well as physical exam findings of joint swelling, stiffness, or tenderness of palpation, can be pretty nonspecific, and so imaging can be very useful in this case. So let's start with our weight-bearing AP view or anterior posterior view. So this is where the patient is standing with their knee in full extension. Here we can see the four bones that we've already mentioned, as well as this space between the femur and the tibia. The image that you're seeing here is of a normal knee joint, so you can see this very clear, well-defined space between the femur as well as the tibia. And this is where our articular cartilage sits, but because the cartilage does not appear on an X-ray, we see it as this well-defined space. And if you're wondering why, the reason we obtain a weight-bearing AP view, it's because we really need to make sure that we force the two bony surfaces together. If we obtained a non-weight-bearing X-ray, then a person with bone-on-bone arthritis may actually appear to have a decent space between the tibia and the femur because the two surfaces of the bones actually relax away from each other. So that's why you'll often hear the term weight-bearing being mentioned on imaging. So now let's take a look at an image in which a person does have arthritis of their knee joint. Here you can see that well-defined space no longer exists, and we have what we call joint space narrowing. And besides joint space narrowing, another finding that you might see is subchondral sclerosis. This is a term that might get thrown around on a test question, so just be familiar with this phrase. And what happens here is that as our cartilage wears away, our bone is exposed to these abnormal forces, and so it tries to repair itself. And through this remodeling, the bone comes back thicker than before, and so it appears as this abnormally white, bony tissue along the joint line when compared with the rest of the bone. And you can remember this finding by the name itself. So sub is below, chondral is cartilage, so below the cartilage. So we're talking about the bone right below the cartilage here. Another finding you might see are osteophytes, and these are bony proliferations that most commonly develop along the margins of the joint. These are very common findings, and they're considered a hallmark of osteoarthritis actually, so make sure to keep this in mind. So we've gone over some key imaging findings from joint space narrowing to subchondral sclerosis as well as osteophytes. But now, what do we do about knee osteoarthritis when it fails conservative treatment? So this brings us to what we call our total knee replacement. So this is where an orthopedic surgeon will cut a small amount off of the very surface of the tibia and the femur and then bind a cap of metal and plastic to the ends of the bones. And you can actually see this cap here on this image. And the idea behind this cap is that it's going to take the place of the lost articular surface cartilage. There's also something called a partial knee replacement, and this is where only part of the knee is resurfaced, like the medial tibia and the medial femur, for instance. All right, everyone, so just to summarize, we briefly went over our knee anatomy, so make sure you know your 4 bones, your 4 ligaments, and your 2 tendons, as well as your cartilage tissue, so your medial and lateral meniscus, as well as the articular cartilage tissue that we discussed. We talked about how osteoarthritis is due to articular cartilage damage, as well as what findings to expect on imaging. And then we briefly discussed our surgical treatment options, your total and your partial knee replacement. I hope you found this video helpful. If you did, please make sure to like and subscribe. And as always, good luck studying, everyone.